Hello, hi everyone. Okay, so I will start now with this case. The thing is that what I do prefer when I give you the history. So I'm starting now from case number 2, okay? Because we discussed the case number 1 last time. So we're starting with case number 2, and this is the case which I did send you a history sheet that basically said that this is a breast lesion, U3P3, 50-year-old female core biopsy. What we will tend to have in the United Kingdom, you need to understand one concept which might be important relevance in some cases, that we might be doing a core biopsy in something that we call a screening program, and we might not be doing, or we might do it for if a patient is presented with a breast lump or changes in the skin of breast or heaviness or something like this, or an incidental finding on a requested radiology. But what is the difference is that in the screening program, you will tend then to have a lot of cases with breast calcifications. And there was a case that used to come year in and year out in the exam in the last few years, but I think for the last 2 or 3 years, they stopped now, which was a case which showing microcalcification on a screening. So they did tell you that there was some echogenicity and density changes on the mammography or on the ultrasound. And then what tends to happen that they give you the breast with some form of a benign changes that you tend to exhaust yourself describing in and out and in and out. And then you spend a lot of time and you give your final diagnosis, which is something like, let's say, sclerosing adenosis. And then you tend to forget completely about the fact that there was a history or the case was done for microcalcification. And if you have a microcalcification in a case and you fail to comment on the fact that there was a microcalcification, despite that you've written a brilliant history, you will be failing into that case, because what you should have done, you should have categorized the case as what we in England will categorize the case as a B1 category. Now, we tend to use the B1, B2, B3, B4, B5 categories. And if you are not familiar with how we tend to use those categories for the exam, then ideally what you should be doing is you will have to go to the data set. We have mentioned in our data set, and you will find the two data sets in the college website for breast pathology. One that is purely directed for the core and the biopsies, and the second one will be directed to the resection. So the resection one, you will find it very useful when you go for the macro station, while the biopsy one will tell you in details, which was updated last year, how we approach the B categorization. So anyway, this case does not have neither this or that, and basically the case is, as you can see, there are multiple cores here, and let me just close the annotation here. So you can see that there are multiple causes. So this is, I would consider it one of the nightmare for the exam. Now, the reason why it can be the reason why it can be nightmare, because you have a lot of tissue here to deal with in the exam, and you only. Hello, I am back again. I'm so sorry. I just keep disconnected. And I don't know, and I'm not sure why this is happening. I'm so sorry. So we are back again into here. So, as I said, the problem here that you only have 2 minutes to write your findings. So I am going to, for those, some of you might have seen these slides, some of you might not have seen the slides. So just in terms of silence, I will just go through this in a medium power, and then I will go through the findings with you in a second. But feel free, if you do see some of the positive findings throughout, just please send it over, and then we will discuss what your feelings about these findings are, and then we will make our minds up about it as well as we go along. So I'm just going through it now in a slow motions, and then I will stop and see what is your feeling in general about what you have seen. I'm sorry, I have to be quick because we have to go through some of, or a good sum of cases if we can. So I saw a lot of you guys writing columnar cell change and fibrocystic change. You put B1/B2 in some of the answers, so I will come across this in a minute. I'm just will try to go through all these sections, and then we will see what would be the best categorization here. Some of you said sclerosing adenosis. Okay, we will come to this as well. Okay, so I totally agree with you guys that this is a benign breast category, which will be B2. I wouldn't put it as B1 because you already see some abnormal changes. Of course, I didn't stop by some areas like here, but yes, by all means, there is a columnar cell change, which you tends to identify it as this indulated ducts, and the indulated ducts, providing that the epithelial lining is not atypical, then you will go for the benign category of the columnar cell change. Yes, if the question was having a microcalcification in it, I would not put this as a B2, and then I would have, even that you found a lot of changes, I would have put it down under the B1 category, because you still do not see the real changes which you can get. Now, I can tell you as well that when this case was selected from the past presenter website, it has been put down under the categorizations of a radial scar. And I can see why some people might think of a radial scar for a case like this, because you can get some increase of the elastic fibers, which can go in between the lobules. You can see it in some areas, and then people might say it can be or may represent a part of a radial scar, and then this will categorize this as a B3 category. Now, one of the things you need to understand about the radial scar in terms of morphology, that on the excision, it is a very easy case. And the reason behind it, because you can see the central scar fibrosis, the radiating fibers that goes out in a circumferential fashion, and then subsequently you will be able to get the diagnosis correct. However, in the biopsy, the story is a little bit different. And the reason behind it, because you cannot see the entire lesions, but you can see sometimes only the edge of this lesion. But one thing which is quite important in this field here, which I'm keeping centralized now in your field, that you can see the radial scar. When you see these fibroelastic bundles or a finger-like extension that goes from a middle somewhere and start to extend toward the periphery, what you will be wanted to do is, or what you wanted to identify in radial scar, that the fibrous bands actually goes around tubules and lobules. And this is one thing that a lot of books doesn't tend to describe it a lot. You can see with my spotlights that I'm trying to use now on the screen, you can probably see the fact that what you have here is not only a tubules. In actual fact, what you have is a tubules that's trying to form some lobules. And in between those, you can see there are some fibrous scarring that goes and transects in between those. And the problem on the biopsy, obviously, that when we started the biopsy away from this area, yes, there were columnar cell change, yes, there were fibrocystic change, but the problem here that you tends to discard these areas as probably a little bit of adenosis, but what it is that this is not the normal lobular architecture. The normal lobular architecture, if you go across the reality of it in a normal breast tissue, you find a lot of lobules and not a lot of ducts. But what we tend to see here is a little bit of mix of both. You have a lot of ducts and a lot of lobules. But nevertheless, the presence of the lobules will take it away from the fact that this is a sclerosing adenosis case. So what I wanted you to do is basically, I wanted you always, before you come to a diagnosis of a sclerosing adenosis in any case, that you have to define really what I do see here. You see, you can see that these ducts here are trying to branch, but also they are trying to bud. And if they are trying to bud, then that means that these are trying to form lobules. And this is the classical of lobular ductal differentiation here. Now I am putting it on to show you the density. Obviously, this is a scan slide. In real life, you'll be able to see the elastic fibers properly, but you can see that there are two types. There are a little bit darker, the elastin fibers here, and there are paler, the collagen fibers. So I kind of agree with the past presenter login of the case that this is mostly is to represent the radial scar in areas, and which if we are to talk about radial scar, obviously radial scar is for me or for the college will be considering this under the category of B3. Now B3 is big, and the reason behind it, because as you know, a lot of people nowadays tends to biopsy the radial scar, and the more that we sample of radial scar, we start to see lobular neoplasia, we start to see low-grade DCIS, and we started to see this columnar cell change in association with it. And we also tend to see, or we started to see more of the tubular carcinoma. So now this is important. But what is my approach for these biopsies? If you have a doubt that there might be a radial scar, like you've seen a lot of scar tissue just radiating between tubules and lobules, which shouldn't be the case, because normally you don't really get this scar fingers like things between different lobules, and not in that categories, and then you don't get two types of collagen with or elastin mixed with collagen. But if you are in doubt, just say I cannot exclude it. You see, so just be descriptive as much as you can. I told you before, it is not about trying to reach the final diagnosis, but it is trying to be a little bit descriptive. And then it is sometimes not very wise, I would say, to link yourself to one single diagnosis. So don't try to link yourself to one single diagnosis and say it's a sclerosing adenosis, you know, or that's it. No, it is not. In the best cases, you know, it's like what you deal with it for real life. You have to be descriptive as much as you can. I know if it's a cancer case, that's absolutely fine. But here in the breast core biopsies, we are not in the territory of is it really benign or is it really malignant only, because we have other categories. We have the B3 categories. Now, can B3 comes in the exam? I think radial scar can come in the exam. There's nothing to stop the examiner from bringing radial scar, but now you know that there is another pitfall case, which is a micro calcification. If you really don't see micro calcification, then you have to say it. You have to say, I don't see it. But please, before you reach to the conclusion that you did not see microcalcification and you only saw benign changes, for example, just make sure that you polarize your microscope. And then you basically look for the other type of calcifications, which can not be, it's not like the classic one, and then it's the name is just flied out of my head now, but nevertheless, you know what I mean, and just make sure that you do this. Yes, absolutely, the columnar cell change, and you will see it in the areas of radial scar. You will see, so this I'm just replying for one of the queries now. And as I said, there is, because we biopsy more of those, because we can see the abnormalities, then you tend to see a lot of incidental finding of radial scar next to cancer. And most of the publication, the recent publication, the last 2 or 3 years will tell you the link between radial scar and the cancer probably related to the frequent sampling of radial scar rather than the fact that they are truly predisposing to cancer. So radial scar on its own right does not produce the cancer. So this is just to highlight that case. I will move to another case now. So just bear with me for a second, and then we will I will share the case as soon as I put it again on the screen. So this second case, which I'm just going to show it to you now. This is another case that I also got it from the Path Presenter website. And one of the good news about these meetings now and in the future, what will happen is that we will be, I contacted Leeds virtual histopathology website, which I'm sure you all uses, and they granted us to use it for this teaching. So I will be able to freely use the Leeds website, which I will be probably also using it today to show you some cases. And this is now official, and they are happy for us to use it, providing that you guys know that the cases are from there. So now I am just going quickly again through this case, and I will zoom in and out as I go along. And forgive me that I have not given this format of teaching before. So if you feel a little bit uncomfortable with that, then please let me know. If you feel that my control is very wobbly on the screen, okay? But I just will stop here. We are talking about a situation that's very similar or overlapping to what we've just discussed a minute ago. Okay, and basically, you can see now this is demonstrating a better view than the previous case of this discrepancy of the type of the connective tissue that you get in the fields. But I also wanted you to understand the fact that this is the classical one, which you see the radiation that's going in all directions, and then it entraps tubules, but with the tubules are going to bud. You see, the normal tubules does not bud. This, in order for it to start this budding, that means that you are trying to form lobules. Yes, depends on the age. You see, some age group of categories, you probably won't see the proper lobules has been formed, but you do see the point, you see the budding, and this is the point that I'm trying to highlight for you guys, that you definitely have these two types of connective tissue. You have entrapped ducts, and you can see the budding. So these are like lobular ductal units in the generalized sense. And this is what I mean by that. And then you are again in the area of radial scar. So yes, automatically, when you see a radial scar in the exam or in real life, either way, you have to search carefully now for the tubular carcinoma. You have to search carefully for DCIS. You have to search carefully you have to search carefully for the lobular neoplasia. And you also have to search for the columnar cell change, as we just discussed a minute ago, as well as you need to discuss to search for the flat epithelial atypia. So this here is a good examples of the columnar cell change, and you probably you are able to see the snouting, which comes from the surface, the indulation of the ducts, and they are usually dilated. So if you really are judging columnar cell change in a very small ducts, just better to stay away. These ducts with columnar cell change are usually indulating, and they usually will be slightly dilated. So don't go in agony into this. This is not going to fail you or pass you in the exam anyway. So I know there were a lot of big, very respectable speakers across the board in US CAP and everywhere on the pathcast. They become very focused on these lesions, but on the grand scheme of exam things, for me and for you, the fact that columnar cell change, when you see it, you need to make sure that you don't miss low-grade DCIS or tubular carcinoma, which might be next to it. And you don't need, you also do not miss microcalcifications, which usually can be associated with this. The other things which I would like to highlight, that, as I said, there is that triad of lobular neoplasia, columnar cell change, and tubular carcinoma, which can be present next to each other and in close conjunction with a radial scar. So now you know that rule. Then whenever these type of cases come in the exam, I think you will be kind of more comfortable with that. Now the question was about if I am to put this case as another radial scar, which it is, then that will go into the category of B3. Now, because of that link that I told you about, that the people think that there might be on the large scheme of a vacuum or a wider excision, that you might find a tubular carcinoma or in situ disease, then therefore people tend to categorize this as B3, so you need more tissue to analyze. However, sometimes the surgeons might then do only a vacuum rather than anything else. Now, why I have been very anal about this? Because all what I have just been telling you are to add into your extra points. So if you are wanted to win something, you have to raise that debate, which I've just said, about the link of the radial scar with the background in situ or lobular neoplasia or the tubular carcinoma, and just say why, because some people think that, or recent publications show that this is probably a correlation rather than a direct relationship, as radial scar is on its own is a benign condition. So this is just to highlight that. Now, I wouldn't, if the epithelial proliferation, which I've just showed you here, I'm sure you all know that this is benign. You can get this type of slit-like spaces. They are not particularly punched out. The cells usually will be streaming around, and they are generally small in size. Don't forget, and there will be a mixed population, of course. I'm not going to go now through the differentiations between a DCIS and epithelial benign or usual ductal hyperplasia. I'm sure you all know that very well, but I would tell you a little bit more about it when we come to a case that's positive with this. Now, yes, by all means, if I am to because some of the questions said there are areas of this area can be like a sclerosing adenosis, but I will tell you the sclerosing adenosis shouldn't have an increase of elastin fibers in between. The other things about sclerosing adenosis, which I will go through it in a few minutes, that sclerosing adenosis does tend to have mainly tubules, so it would not have the budding that's trying to form lobules. So this is one thing that you need to be aware of. The other things as well, so this type of structure you should not get in sclerosing adenosis. They are usually small tubules. They are usually this type of tubules that you tend to struggle a lot to identify if you really see a myoepithelial layers or not. But in actual fact, if you go to any of these tubules, it's very easy to identify that there are double layers here. And therefore, this is why I wouldn't only focus or rely on two lobularities. And I will tell you why in a second. So in order to highlight this or to answer these questions, I will take you directly to this case, which is case number 4. So before I move to case number 4, case number 3 was a replica for case number 2. They are radial scar, and as I told you, the data sets usually will put them in the B3 category, but you guys will have this categorization that we use in England as your homework. Now, radial scar, I would say it is the exception of what can come as a B3. A lot of the other B3s might not turn up in the exam, but don't take my words as granted. But historically, usually the college will try hard to stay away from the controversial areas or the areas that come with a various diagnosis. Now, this is another core biopsy. You can see that I probably have given you a lot of similarities in patient age, because in this phase, I do not want you to rely a lot on the history, especially in the short surgical. And for now, it is one thing that when the history is very relevant, I will tell you. But here, you probably will correlate the history to the ultrasound finding and the clinical findings, which are demarcated by the U and the P categorization that I gave you in the heading. So to go by the U category or by the P category, it is good things to correlate it down when you do your additional points to try to score more details. You can say radiologically, this may present as a mass, and it can be overdiagnosed sometimes in radiology because sometimes it looks like a speculated lesion, radial scar, I'm talking about radial scar, and then therefore it's easily diagnosable on the imaging as malignant or suspicious for malignancy. So this is another things that you can also add in your brownie points, or how you will try to score an extra points. All of this, as I said, as we go along the cases, I will try to build the brownie points. What I cannot do, I cannot be standing by the case for an hour trying to illustrate for you how you can put a brownie points for every single case, but collectively, as we go through more and more cases, you will understand how the game is played, because you need to score, and there is no other way that you need to score. So I will just keep moving now into these slides, which you can all see, I guess, here. And we have 2 cores, so don't forget to count count the number of biopsies that you see, and visit them all, please, because the last thing that you want is not to visit them all, and then you will become in trouble. So I'm going through this now, and I am waiting for some suggestions of the answer. I will go in high power in a second here. And as you know, we have the technical difficulty today. So for those, I understand that you have a very valuable time, and for those who would like us to finish by 7, also let me know, and I will finish by 7, although we have a lot of technical difficulty today. There's a little bit of some calcium here. So what do you think? So majority of you now think that this is sclerosing adenosis, microcalcification, also seen. Microglandular adenosis, right? Let me go again into low power and give you another minute with this. And then I will go through it as well in a little bit of more details. Now, I tend to agree with those who thought that this is a B2 sclerosing adenosis. But let's analyze this case. The problem of the exam is these cases. You know, these are the cases which will put you in a lot of trouble. Now, you can see that for those who think that it is easy to identify the lobular architecture, which a lot of people, when they teach you in breast pathology, I'm not breast pathologist, I'm a generalist, but I heard and I attended all these teaching that we all have been through. And a lot of them will tell you about the lobular arrangement of this. But in actual fact, when you see a curve like this one, which we have, that's full of ducts and glands from top to bottom, and you are trying to figure out, do we have really a lobular arrangement or not? I would say you're mad, okay? I agree on the resection specimen, you probably will be able to see it, but the problem here of what we have is that you cannot define this. You know, you cannot define this architecture in the core, and therefore you have to go by some other features which will be more helpful to try to define this. So let me just see how we will be able to see something like this. The first thing that you need to understand when you identify the lobular adenosis, I'm sure for the expert breast pathologist in the meeting, they will be able to identify this a little bit much better than I do, but please forgive me, and I will try to tell you how we approach this in England, how I've been taught this. Now, the first thing is that what I have been told to do, that you need to find a core where you feel that this is where the center of the problem is, right? So number one, define where your center is, and it's not difficult to identify the center of the problem on the biopsy, because what you need to do is to find the areas with the larger caliber glands. Okay, so you find the ducts that are large, and you tell yourself, okay, you know, I think that this will be the core of my biopsy. And this, I would consider that this is the core of the lesion. So the larger ducts here, and as you go peripheral, and you can see here, there are some large ducts, and then as you go peripheral, like if you go to the periphery of the core, you can see that the ducts are getting smaller and smaller. Now, for anyone who felt, and this might be tubular carcinoma, that's a good thought, because this is your main differential, and this is what we are trying, the problem which we are trying to resolve. So I will try to resolve it for you a little bit here. So obviously, what you need to do is to say that this is, you can see the ducts are getting smaller. So this number one, which can tell you I am sclerosing adenosis. Number two, you will try your best to identify some myoepithelial cells, and like this guy might be a myoepithelial cells. The problem of identifying the myoepithelial cells that you will have to be personally convinced that you see them in every duct, because don't forget one of the problems of the tubular carcinoma that it will tend to have yes, the answer is sclerosing adenosis. So for those who are eager to know the answers, sclerosing adenosis. So going back to here, the problem of tubular carcinoma that you might actually find some cancer glands, especially on the biopsy, that's lying next to a benign gland. So you must be convinced 100% that you do see them. Now, for those who felt that this might be a microglandular adenosis, one thing that microglandular adenosis should not have is myoepithelial cells. But another important features, which is also equally important, that you tend in tubular carcinoma, people will tell you that the glands tends to stay open as you go more peripheral, while in sclerosing adenosis, the glands will collapse. So basically, you start to see some glands here at the periphery where you do not really see alumina. And this is a phenomena that you can see it a little bit here. You can then, as you go more peripheral, you can see more of the glands becoming a little bit of a slit-like glands, like the one that you tend to see it in fibroadenoma and things. But what it is that these features is important, because you don't tend to see these features in tubular carcinoma. The lumen tends to stay a little bit more patent. The other things as well, which we do in breast pathology, and we try to highlight as a difference between this and sclerosing adenosis, is the lumina, which I find sometimes difficult, but tubular adenoma usually will have a round lumen, you know, a very round patent lumen. And while in tubular adenosis, you tend to have a change of the shape of the lumina. So some of them becoming a little bit more irregular, some of them will become a little bit like elongated, some of them will try to give you a slit-like appearance. But this phenomena, you tend to see it more with the sclerosing adenosis, but you don't tend to see it with the tubular adenoma. And there is another important features as well, which is important to highlight. If you go back to your Ackerman and Rosai, what you will find out that they will always tell you that the cancer cells in breast pathology, ideally, they get graded per size, like 2 times difference, 2.5 times more, or more than 3 times the size of the normal ducts in the background. So if for example, you can see these ducts here in the middle, that very large one with the secretion inside, if you tend to see that the fact that this is the size of your normal epithelial lining and myoepithelial lining, then ideally what is the tubular carcinoma should have a little bit of a larger cells. So you are talking possibly about 2 times difference in terms of size, but this is not happening. I don't think the desmoplastic stroma will help you a lot in differentiating between the two. There was also another one or another point which has been mentioned briefly before in some textbook, you might find that the irregular or angulated ducts. The word angulated ducts, like you get a more angulated ducts with a tubular carcinoma, but you tend to have a simpler ducts and not angulated. But there is a caveat here, because you need to make sure that this duct, like for example, these ducts, let me just put the laser pointer again here, like these ducts which I'm trying to highlight now. This is not particularly angulated here, and this is because it is just a cross-cut of the ducts that's coming in several aspects. But I do find personally identifying the angulated ducts difficult when it comes to the tubular carcinoma. And this is just to highlight these differences. But in order to try to make these equations a little bit simpler to you, let me just show you a tubular carcinoma that I've just put it now in the middle of the screen. And this is now from Leeds website. And I just wanted to show you the differences now, providing also, obviously, the fact that this is different because that's not a core biopsy, but I didn't find on the core biopsy for now, but I will try to find you one on a biopsy and put it later. But what it is that you can understand now that, okay, we have the core or the heart here, but as you go more peripheral, you still find some uniformity of the size of the ducts. So you can see that the ducts are not getting smaller, they are not getting larger. But they are very uniform. The other thing that the ducts are staying patent. So this example which I'm showing you now, that's the tubular carcinoma. So to avoid confusion, this is a tubular carcinoma. And what you can see that the ducts are very patent here. And then you will go to some of the ducts to try to figure out this angulation, which I personally, as I said, find it a little bit tricky and difficult. But let's try. We will not lose anything. Probably difficult, you see, but is this a cross-cut or this is an angulation? So this is very similar to that situation which I showed you before. You can see the struggle here now to identify that there is a definite myopitheal cells. The problem is, of course, if you start imagining some fibroblast or you start to get a little bit of desmoplastic stroma, you might start imagining a lot of myoepithelial cells into a field like this. But like here, for example, if I go here into these ducts and put it in the middle, and I just will highlight here, would I consider this as a myoepithelial cells? Would I consider those two? You can see they are trying to become a double row. But one thing which is quite important is the size. The size of the cells here, it's getting a little bit larger. And this is an important thing. And this is a kind of like a theory that because people are very focused on differentiating between what I would say the DCIS and the usual ductal hyperplasia in every teaching session, they tend to forget to focus on the actual fact or the basics of Rosai when he mentioned the fact that you will tend to get what do you call it, the larger cells. You tend to get these larger cells. You can see there is columnar cell change quite scattered throughout this, maybe some lobular hyperplasia or neoplasia here. And then you see the tubular carcinoma. That is just the triad which I have mentioned before. The tubular carcinoma, as a brownie points, what I would like you to understand is the fact that you need to still do your immunomarkers. So you would say, I will, if I can tell you, if I am to go and diagnose a sclerosing adenosis or a complex sclerosing lesion as a B2 without doing any immuno, that will be a madness. And you are allowed in the exam to do your myopitheal markers. The myopitheal markers which we tend to use in the UK are the P63 and CK56. I know some institutes use the CK14 instead of CK5, but traditionally we use the CK5 and the P63. And it is good that you will have to mention this as additional work. The other things as well, which you can put in brownie points, of course, that the data set item, if you get a case like this. So what I would be expecting you to do in a case like this, if you see the lesion, that you will have to measure it for me. You will have to give me the TNM classification for it. If you see a margin, you will have to also, if you see a margin, you will have to measure it, say to the inked margin, the distance is. The other things is that you need to grade the tumor. You need to tell me some other information like family history. I cannot remember the name of the triad. I'm sorry. I will try to remember it. It might be it wasn't triad. I cannot remember what it was called. As I told you guys, I'm not really a breast pathologist, but I will try. It's just sometimes you get a mental block against few things. But the other things about tubular carcinoma to mention as well, it is very unlikely for tubular carcinoma to have a positive sentinel lymph node, although traditionally they will do a sentinel lymph node, but you can say that usually this is not associated with a nodal metastasis, so very, very low risk. The patients do very well on terms of prognosis. And the other things as well is to mention the BRCA testing and to mention also the MDT discussion. And so you can say if the patient have a positive family history, BRCA testing will be done for her, for relatives, daughters, whatever it is, just to show the people that you are tuned into the BRCA testing. The things is what I wanted to say about the BRCA testing is that BRCA testing does come in these OSPI stations. You know, we have two stations, one with the problem solving one, and one is a clinical thing that it's like an essay. You write what you are going to do. One of them the management one, you will take it and discuss what you wrote inside a room, and you will have a live OSPI. The other one is just a theory things. You don't go and discuss it anywhere. But traditionally, what tends to come into that station, which one of the OSPI station, will be either a case or a whole discussions about the BRCA testing for breast pathology. Sometimes you get the BRAF testing for the melanoma. So this is another area that they love it. Another one will be the egfr for adenocarcinoma of lung. So these common themes, these are kind of like you have to download a paper about this BRCA in breast pathology, about BRAF, and then you just read the paper, and this is all what you need. Then you will be able to pass this. The problem is, if you enter that station and you don't know a lot of details about BRCA, testing, and then you don't have anything to write, and then you are in problems. I remember in my exam, the one that I got was the egfr. I remember in another exam, and MSI, that's correct, yes, someone wrote MSI. So this is also another important one. I think that's the tetralogy of the molecular testing that we need to be very, you need to know them like your name. You need really to read a good paper about them, understand it very well. MSI will come in the setting of the traditional serrated lesions or adenoma, which I will be putting a case for those. But those are for those. So what I wanted to say, and I will close the sessions now with this, because I know, guys, you have to go and do other stuff in your life, and I'm terribly sorry. I don't know why the link didn't work when we sent it the first time. It was just automatically generated, but here we go. Thank you. So what I wanted to say about the MDT writing, it is if you write MDT is a multidisciplinary meeting. For those who don't work in the United Kingdom, what we mean by that is that it's a cancer meeting that we tend to do it on a weekly basis, discuss all the cancer that comes with radiologist, oncologist, and surgeon, and decide on further management. So what we need to do, when you refer a case to cancer meeting, just it is good, or to the MDT meeting, just say the case will be discussed in the MDT meeting. You will be scored for mentioning this, you will gain a point for that. And then subsequently, you will be able to just tell me why you're doing it, you know, like, because just to discuss the completeness of excisions and further management. Try to be a little bit talkative. Now, if you are in the case which basically might be like the core biopsy. If we go back to that core biopsy, which we just been with a minute ago, and if you are in doubt, I just don't panic if you are in doubt, and don't panic if you felt that, why did I get something like that wrong today? Well, it's good to get it wrong today, but it's to try to avoid getting it wrong in the exam. But what I mean that if you are ever in doubt, just say, this is an irregular ductal proliferation, okay? Listen to me here carefully, okay? But don't do that. Don't make it as your practice. But if you think, if you get this panic attack and you start trying to breathe very fast and you cannot, you got mental block, you cannot remember anything in the exam, that's fine. But what you need to do to stay composed and write the following. You just write, this looks like a complex sclerosing lesions with a lot of ductular proliferations. There is uncertainty about the presence of myopitheal cells histologically. Therefore, my differential diagnosis is between sclerosing adenosis or complex sclerosing lesion and or tubular carcinoma. And I'm going to do the immunohistochemistry for myopitheal markers to differentiate between the two. Now, even if you put in between brackets favored, for example, tubular carcinoma, providing that you've told the examiner that you were not sure and you are going to try to differentiate between the two, then you will probably be getting two and you will save the case. Yes, by all means, I do not recommend that you go for that options, but there will be the circumstances and the situations where you feel terrible, you didn't sleep the night before, and you cannot think during the exam, you forgot everything, but at least then stick to being descriptive and try to score some marks. I just covered a few of the first case of the breast, which can or usually come in the exam. I would say it will be, if I tell you 90% of the exams come to target the areas between tubular carcinoma and sclerosing adenosis, then I will be correct. So personally, what I did collect from our lab around 100 cases of both, and I sat down and I read them and I went through. The difficulty of reading it only from textbook that you only see as still pictures, and these criteria which I told you about is mentioned about 3 or 4 textbooks, so you might not have time to go through all these 3 or 4 textbooks to collect these criteria, but now you know everything was mentioned about it, how we would differentiate cell size, presence or absence of myopitheal markers, the shape of tubules, the lumen of the tubules, the glands getting smaller or maintaining size, the lobular architecture. If you guys are very happy about the lobular, but I told you in biopsy can be difficult. But if you, what I mean, undulated tubules, all of those, try to apply them now. So for example, you go to Leeds website, you go to any other website, just get them all in front of your eyes, try to apply these criteria on every slide, and that will work. The other things as well, and that's the last point that I will finish with now, that's one of the things when I was doing mocks, and I tend to mock myself on the real exams, when on the real Leeds, as you know, Leeds website has got the real past exams, and I mocked myself on those. So I was putting exam conditions, but I used to do the case over 8 minutes. And you must practice to write everything in 8 minutes, because you need to get feel of how the 8 minutes feel like. And the only way that you will feel how the 8 minutes will feel like by keep on doing this on 8 minutes mock. If you are practicing on 10 minutes every time because someone is doing a mock for you, or you're practicing on 10 minutes, believe me, you will always run out of time in the exam, because there's a lot of distractions, a lot of people walking, talking, you know, things like that. So just make sure that you do all your mocks in 8 minutes, and then believe me, you will thank me after the exam for practicing it on that. I used to also to write my micro last. So if I know the case and I know what I'm going to write about it, I start with diagnosis. So I leave the page, 1 page empty. I go for the second page, and then I write all what I wanted to write about the case, diagnosis, differential, additional work, and then additional information. And then I go back to the micro and quickly scribble through it, because I told you in the exam, the micro are the least one that carry weight, while the others will be the most of the things that carry weight. Once again, I'm so apologetic for what I have, for this glitch with the technicality today. I hope that you did find that not very boring, and I hope it was useful. And breast book, sorry, if there is a question, breast book for FRCPath Part 2, breast book. I cannot publicize because we are not in a platform. I said that this is non-profitable, this is free. I cannot give you the name directly, but if you email me, I might be able to give you directed advice, but I cannot say it in public. I'm so sorry. But thank you very much, and I hope you guys find it useful. And now this will be the trends of how we will be doing this. My email is easy for all of you. It is ali.histopathology@gmail.com. So that is, I will just type it here, and you will all be seeing it. I know a lot of people would have heard this information before, but what I tend to tell you to avoid as well is the teaching sessions which can give you, for example, the entire thyroid pathology in 45 minutes, because it's only the geniuses can do that, but this is usually, I find it a little bit difficult in preparation for the exam to have an entire specialty for 45 minutes. As you probably seen, we stood by one case for approximately an hour, and I'm not a breast pathologist again. Some of what I might say people don't like, that's absolutely fine. Some might find it useful, that's absolutely fine. We are open community here, guys, and thank you very much for staying tuned in. And I shall see you again on Wednesday, I think, and we will carry on. I think majority of you now have seen or has gotten access to the slides and the history sheets. And if you don't, please, you can ask me or ask Angie. And I cannot thank Angie enough for looking after us, and after this meeting, she has got pivotal role in all of that, and please thank her too. She is really brilliant and a star in our department. Thank you very much.